Hello, this is Camp with Nursing Camp, and this is Cardiac Camp and the Heart Assessment. And what I'm covering today is about cardiac output and the problems with cardiac output and the reasons behind cardiac output. From my hemodynamic measurements overview sticky note found on Nursing Camp, Pinterest, Facebook, nursingkamp.com. All right, let's get into it. Well, the first thing that we're going to look at is with cardiac output. Cardiac output, as we talked about previously, cardiac output is 4 to 8. And cardiac output, how we figure that out, CO, we put the 8 there, and then we have half of that is 4 to 8, and that's liters per minute. Well, the problem is that we don't normally have cardiac output, so because we need hemodynamic, like SWANs and advanced hemodynamic parameter measurements. So we do have mean arterial pressure, and mean arterial pressure can give us perfusion of that cardiac output. That needs to be anywhere from 60 to 65, and we talked about how we figure that out. 2 times diastolic divided plus systolic divided by 3 gives us a mean arterial pressure, and it should be greater than 60 to 65. If it is, they are perfusing their organs, like their kidneys, liver, etc. However, they need to be 70 to 75 for their brain, so they have, good perfusion. That's why restlessness and changes of level of consciousness is always acute in NCLEX questions in nursing priority. Okay, so decreased cardiac output. Why do they have decreased cardiac output? Well, we covered recently in a previous lecture about ejection fraction and damages to the vessels and to the heart. So let's look at that first. So MI, myocardial infarction. In a previous lecture, I'll talk about myocardial infarction and how that happens and see that lecture for that. But in myocardial infarction, why does the cardiac output decrease? Well, we have the vessels here. We have the right atrium, right ventricle, and so on. Well, the issue is that in the ventricle, this muscle tissue is damaged. Okay, when this muscle tissue is damaged, it can't cardiac output. So there's no cardiac output. So when there's no cardiac output, you have decreased perfusion. And it's because of this damage. So MI causes decreased cardiac output. Next is hypertension. Well, hypertension is interesting because of hypertension is a constant pressure going into the heart. Okay, high pressure volume. Well, the problem with this pressure volume is that the heart can't handle this extreme pressure going into it. So I like to think of like a balloon or something like that. When you start to blow it up, is what happens is the heart becomes so tense that it becomes hypertrophic. And what I mean by hypertrophic is big trophy hearts. So this muscle starts to build up. It gets really hypertrophic. And I always think of big trophy hearts. And the way I think about that is that if the heart is so big, there's so little amount of space that the vessels can't accommodate any fluid. So therefore, less fluid in because there's no space means less out. So cardiac output starts to be decreased. Next is valvular heart disease. And when I'm talking about valvular heart disease, it depends on which valve we're talking about. In a previous lecture, I talked about the different valves and the causes of those problems and the location, but see that lecture for that. Now, what we're talking about with valvular disease is there's a problem in these vessels, these valves right here. So on the right side, you have tricuspid, and on the left side, you have mitral. Well, the issue is that these valves, they need to close, okay? And if they're not closing because of either, calcification or something like that, they don't really snap shut. Well, that means there's a little regurg that starts to go through. And it shouldn't happen. They should just be snapping. And that's where we get S1 sounds, right? These are your atrial ventricle valves. That's S1. Well, if there isn't a clean valve, or there's some sort of MI that has caused damage that these chordae tennae can't pull this valve closed and open. Well, the problem is that this regurg over time makes this heart harder to work. It can't quite take the volume in and then eject it. And so because of this valve, it's very important these valves close, snap, S1, lub-dub, that sound. Well, if there's a regurg or something's wrong in these vessels and these valves, what happens is they don't get that. They don't get that snap and that good Starling's law. There's a recall from A&P, right? So the greater the fill, the greater the pump. Well, there isn't a good fill because the valve is problematic. And so they get this regurg. Well, the problem with that, it's chronic over time. Chronic over time means that it's a slow process. It's a slow process that new onset murmurs, as signs of this, are always acute. So if you ever get a new onset murmur in a question, in an NCLEX question, never assume that they have that's a normal finding. It's always acute, okay? And that's important to recognize because CHF, which would be symptoms of this, happen later on in life. You don't see it right now. So people with valvular disease and rheumatic disease, we'll cover that in another lecture, is chronic over time. So the nurse, it's very important to recognize later on new onset murmurs. And that will cause a decreased cardiac output. So what does the patient look like? A patient with a new onset murmur or patient with valvular heart disease, as they start to walk up steps, shortness of breath. And that's acute. They should be evaluated by the doctor. Okay, next one. Cardiomyopathy. Cardiomyopathy also causes a decrease of cardiac output because cardiomyopathy, think of big floppy hearts. So now, like a balloon, like I was talking about earlier. Well, the problem with the balloon is you blow up a balloon and you blow it up and you blow it up, you blow it up. Well, over time, that balloon will lose its elasticity. Well, like hypertension and what's the word I'm looking for? Increased blood flow over time will keep on blowing and extending this balloon. What happens is they get floppy and they can't contract, and so therefore decreased cardiac output. So these are all reasons that cardiac output starts to decrease. Cardiomyopathy, that's covered in another lecture, and causes of that. Then we talked about hypertrophy earlier. We talked about hypertension. And hypertension is twofold. It's not only what's going into the heart, it's also peripheral vascular. So if they have their fingers and toes, and those fingers and toes, there's peripheral vascular disease, well, the heart is trying to pump out to the fingers and toes. But there's tension out there. And if there's tension out there, the heart has to work harder. And because the heart is working harder, the muscle starts to grow. That's hypertrophy. All right, next thing is AFib. AFib is a problem because if AFib doesn't have a P wave, okay? So it's just like this. And that's basically the same thing of like a valve problem, okay? So where the vessels are, they would normally go through, the AFib, this isn't happening. The SA node's not happening, so it kind of slushes through. That's called regurg. And what happens is that chronic over time causes decreased cardiac output. No Starling's law. Next thing for decreased cardiac output is dysrhythmias. Like anything like VTAC, VFib, oops, flying away. VTAC, or VFib, that doesn't give you cardiac output. So the patient, that's acute. They have no pulse. All right, what else? Medications. That's called DCAB. Medications are DCAB. Digoxin, causes decrease. That's why we check for apical pulse, less than 60, we worry. Calcium channel blockers like DV, we covered in the lecture, diltiazem, verapamil. Beta blockers, calcium channel blockers, beta blockers, LOLs. Decrease is a problem. And last is fluid overload and hypovolemia. Those are obvious because of that. There's not enough fluid, so therefore there's decreased cardiac output. So those are all the reasons for decreased cardiac output. Those are all reasons why you would have presenting symptoms prior to. Next lecture, I'm going to talk about decreased cardiac output symptoms and how to know when there's a problem. This is hemodynamics. This is Nursing Camp covering cardiac camp, and these are decreased cardiac output. Follow me on Nursing Camp, Pinterest, Facebook. We'll see you next time. Nurse on.